Good afternoon, guys. Today I will be discussing back pain. Back pain, okay? Back pain. Okay, so back pain. If a patient is coming to you, how can I help you, doctor? I have pain in my back. I have back pain. Is it medicine or counseling? You need to differentiate. Dr. Mo, it's not counseling. It's not diagnosed yet. It is medicine. So which structure should I follow? I will follow Dr. Mo, P1, P2. Let's leave a bit of the space after P1. P1, P2, P3, maftosa. So P1, P2, P3, maftosa in the back pain stations. How can I help you? Doctor, I have back pain. P1, P2, P3, maftosa. All right. The patient is in pain, so the presenting complaint is pain. So, sympathy and empathy, which is, well, I'm really sorry about that. Are you comfortable talking to me, or would you like me to give you some painkiller? Doctor, I am comfortable. All right? At any time you feel uncomfortable, please let me know, and I will give you some painkiller. That's it. Can you please tell me more about the pain? So, explore the back pain. Explore the back pain. Can you please tell me more about the pain? The patient will tell you something, or he will not tell you. You will need to use Socrates. Socrates. What is Socrates in details? Can you please point to one finger where the pain is? Side. Onset. How did the pain start? All of a sudden or gradually? Character. What type of pain is it? Stabbing, dull aching, radiation. Does that back pain go anywhere else in your body? Anything that makes it better, alleviated? Anything that makes it worse or aggravated? Timing. When did you start having this pain? And be careful. Be careful. Because if the patient said to you, I had this pain 4 months back, 5 months back, so it became like chronic kind of pain. If it is chronic kind of pain, don't forget from day one, if there is any chronic problem, always ask psychosocial early. Whenever the patient gives you a presenting complaint that is for quite long time, psychosocial, how is it affecting your life? How is it affecting your daily activity? What do you do for a living? How is it affecting your job? Is it affecting your mood? 5 questions, psychosocial, if the pain is chronic. But anyway, back again to the pain. Anything that makes it worse, anything that makes it better. Severity. Severity on a scale from 1 to 10. 1 is being the lowest severity. 10 is being the most severe pain. How would you grade your pain? Severity. So Socrates. After asking Socrates, anything else apart from the back pain? No, doctor. Then, concern. What's your main worry? Or what's your main concern apart from the back pain? So apart from the back pain, what's your main worry? What's your main concern? He will tell you the main concern, then go to differentials, then go to differentials, then go to DDs. And in DDs, I will have 1, 2, 3, 4, 5, and I will add one more, 6. So DDs. What are my DDs for the back pain? The first differential for the back pain that I must ask and exclude in every single patient is coda equina. Guys, coda equina is the most severe urgent condition in back pain stations. You remember chest pain? Always exclude MRI. You remember joint pain? Always exclude septic. In back pain, I will always exclude coda equina. What is coda equina, guys? It is the nerve root ending that's going in the spinal canal is compressed. That's coda equina. Compression of the nerve ending. Coda equina. That can lead to paralysis. That can lead to paralysis and not able to control urine, not able to control bowel. That's why it's a very severe condition. And in this case, I will have to ask. So coda equina is my first differential. Coda equina is my first differential. And that's why I will have to ask about urine retention, urine retention, bowel incontinence, bowel incontinence. And I will ask about, do you feel when you go to pass stool, do you feel the stool through the back passage, or no sensation in the back passage? So that's the sensation in the back passage, sensation in the back passage. Okay, so coda equina, urine retention, bowel incontinence. So it's the opposite, urine retention, bowel incontinence. And when you go to pass stool, do you feel it coming out or not? So that's the sensation in the back passage. However, some doctors, they say that's the typical symptoms, typical presentation. Sometimes it comes with urine incontinence and bowel incontinence. Sometimes some change in the presentation. So you can ask any problem in urine, any problem in bowel, like any problem in urine like urine retention, any problem in bowel like incontinence. Okay, so presentation of coda equina. What is the second? And whenever you have any presentation of this with the back pain, right away, urgent referral to neurosurgeon. Urgent, right now. Why? For MRI. Urgent referral to neurosurgeon for MRI. Second case, the second case is disc prolapse. Second differential is disc prolapse. And by that, I will ask my patient, have you been lifting any heavy weight? Have you been lifting any heavy weight? So lifting heavy weight. And what do you do for living? Job. Does your job include lifting heavy weight? And did you feel any clicking sound? Did you feel any clicking sound in your back? So disc prolapse, lifting heavy weight. Ask about the job. Does it include lifting heavy weight? And always ask about, did you hear any clicking sound? And pain in the back of your leg as well. Pain in the back of your leg. Okay? Pain in the back of your leg. That's disc prolapse. What is the third condition I will think of? The third condition I will think of is multiple myeloma. Multiple myeloma that present with back pain. Multiple myeloma. And this is like what? This is what? Cancer. So multiple myeloma, it is cancer in the bone marrow. Multiple myeloma that causes back pain. So in this case, I need to ask symptoms of diabetes and symptoms of low blood. Oh, Dr. Mo, what are you talking about? Multiple myeloma is a mix of two symptoms. Symptoms of diabetes and symptoms of decrease in the blood. Dr. Mo, can it actually cause diabetes? No, guys. No. This is just something for you to remember, because you are asking your patient here. Nobody knows how you remember the question, but you just need to say the question. Multiple myeloma is a mix of diabetic presentation and decrease in the blood presentation. Dr. Mo, what do you mean diabetic presentation? Multiple myeloma patient will have polydipsia. They will have polyuria. They will have weight loss. So polydipsia, polyuria, weight loss. Okay? Multiple myeloma patient will have polydipsia, polyuria, they pass urine more often than normal, polydipsia, they feel thirsty, and weight loss. Oh, that's like diabetes, yes, but it's not diabetes. And decrease in the blood, decrease in the white blood cells, so they will have repeated infection. Decrease in the red blood cells, so they will have anemia. Decrease in the platelets, so they will have bleeding tendency. So decrease in the white blood cells, repeated infection. Decrease in the red blood cells, anemia. Decrease in the platelet, which is bleeding tendency. Increase in the bleeding tendency. So that's multiple myeloma. 4 is trauma. So ask, by any chance, did you have an accident? Did you hurt your back? Did you sustain any fall? So all these are causes of sport injuries, sport, okay? Sprain. 5, back pain, triple A, abdominal aortic aneurysm. In these cases, I need to ask, apart from the back pain, Any abdominal pain, any pulsatile mass in your abdomen. So triple A is abdominal pain, with the back pain, with pulsatile mass in the abdomen. Pulsatile mass in the abdomen. Do you feel any pulsating mass in the abdomen? Do you feel any pulsating mass in the abdomen? So abdominal pain going to the back, pulsatile mass in the abdomen. And be careful, because triple A cases, I have a case of triple A. In this case, there is number one, you need to exclude the complication. What are the complications of triple A? Rupture triple A. So complication is dizziness or about to faint. So you need to exclude the complication by asking the patient, do you feel dizzy or do you feel that you are about to faint? So, do you feel dizzy or do you feel that you are about to faint? So, do you feel dizzy or do you feel that you are about to faint? What is dizziness? What is fainting? Complication of triple A. All right? And in this case of triple A, the patient will be smoker, heavy smoker, and hypertensive. So, heavy smoker and hypertensive as a factor. Dizziness and fainting, you need to ask as a complication. And the presentation is abdominal pain, back pain, pulsatile mass. And you need number 6 to ask about fever. Why? Why do I need to ask about fever? Why do I need to ask about fever? Fever to exclude any kind of osteomyelitis. Osteomyelitis. So infection in the bone. You need to ask about fever to exclude osteomyelitis, infection in the bone. Number 7 is ankylosing spondylitis. Ankylosing spondylitis. What is ankylosing spondylitis? The patient will come with back pain that's typical to rheumatoid arthritis. So ankylosing spondylitis is a back pain that has the same criteria of rheumatoid arthritis pain. What do you mean, Dr. Mo? Rheumatoid arthritis is pain, stiffness in the morning, relief by the end of the day. Ankylosing is the same. So ankylosing spondylitis is back pain, stiffness is increasing in the morning, and relieving by the end of the day. So stiffness, the increasing in the morning, and relieved by the end of the day. That's ankylosing spondylitis. So only affect males at the age of 40, and they have stiffness in the back that is increasing in the morning and relieved by the end of the day. That's ankylosing spondylitis. So these are the causes, or these are the differentials of back pain, and all of them are conditions. So be careful that you must start by excluding coda equina. And be careful, because if the back pain is chronic, you will bring the psychosocial early. Now, P2 is asking about, have you had this back pain before? Have you had this back pain before? And asking about any medical condition. So back pain before and medical condition. P3 is DESA. DESA, diet, exercise, smoking, alcohol. DESA, diet, exercise, smoking, alcohol. And as I told you, smoking and alcohol will be risk factor for triple A. Ask about back pain before, ask about medical conditions. Maftosa, are you on any medications, any allergy to anything, family history, travel history, occupation and social, which I said, these are only for chronic pain. So chronic pain, you can only ask about occupation and social in chronic pain. If the back pain is chronic, bring psychosocial early and anything else. These are the back pain history. Okay, what about examination, Dr. Mo? In back pain stations, what about examination? After a history, I need to examine. Yes, Dr. Mo. So examination. Examination in all back pain station. I will check observation. Why? Because I said fever, exclude osteomyelitis, hypertension, exclude triple A. I will examine the back itself, the back passage, the abdomen, straight leg raise test. Wow. So in examination, these are the things that I will examine, yes, but filter them. What do you mean, Dr. Mo, filter them? And neurological examination. logical examination. What do you mean filter them, Dr. Mo? Any patient, any back pain, I will examine observation. That's something, no negotiation about it. If I'm suspecting coda equina, what? Coda equina, I will examine the back passage, the neurological. So back passage, neurological. Why? Because in the coda equina, I said to you, it's nerve ending compression. It can lead to loss of anal tone, loss of anal sensation. So I said back passage. Neurological for the nerves, because it's a compression of the nerves and the back. What if it's a trauma? Observation and back. So if the case is trauma, back. What if the case is AAA? Abdomen. What if the case is disc prolapse? Straight leg rest test. I ask the patient to lie flat, and I will ask him to raise his leg. Passive raising of his leg. Straight leg rest test. However, I would love to mention observation, back passage, abdomen, straight leg rest test, neurological in every case. It's fine, nothing wrong with it, but if you can specify as I mentioned, it's better. After that, provisional diagnosis, which means tell the patient diagnosis in his own language, in his own simple kind of talking. Then go to management, and then in management, 7 steps, and that will depend on the case. Now let's discuss one by one and tell you the specific things in every and each case. First case is AAA. Let's bring this here. First case is AAA. How can I help you? Doctor, I have... so you are an FY2 doctor in the A&E, 55 years old, came complaining of back pain since yesterday. So hi, how can I help you, doctor? I have back pain. Well, I'm really sorry about that. Can you please tell me more about it? Ask Socrates. The patient will give you back pain in the abdomen that goes in the back. Okay? Abdomen and back. Alright? So when you ask Socrates the site, he will tell you, doctor, it's here in the back. When did it start? Yesterday. Type of pain, radiation, does it go anywhere else? No, doctor. Anything that makes it worse, anything that makes it better, since when? Since yesterday. Severity, he will tell you 9 out of 10. Then when I go to the questions, yes, there is an abdominal pain. Yes, there is pulsatile mass. So back pain, abdominal pain, pulsatile mass. So make sure you ask about dizziness and fainting because it's a complication. So ask the questions for complication of AAA. Do you feel dizzy? Do you feel lightheadedness? Do you feel about to faint? When I go to P2, have you had this before? No. Any medical condition, the patient will have high blood pressure. And will have diabetes as a medical condition, P2. When you go to P3, the patient will have, will be smoker, will have bad diet, will be drinking alcohol. When you go to Maftosa, he's been treated for high blood pressure but not following up with the medication. Family history of this condition, yeah? Then make sure you ask a few differentials. As you are here, always ask about trauma. Did you hurt yourself? Any fall? Fever. You can ask about any bowel problem, urine problem, loss of sensation. So make sure in every case, back pain, coda equina is a must to be asked. And make sure in back pain, you only need 4 differentials. So if the case is AAA, you can ask trauma, you can ask disc, you can ask coda equina. That's it. So make sure that coda equina is a fixed differential, is a fixed cause on all cases of back pain. Provisional diagnosis. For examination, what would you examine in examination? I said I will examine observation for the blood pressure, back, abdomen. Management, provisional diagnosis, it is a blood vessel in the abdomen, which is like a tube. This blood vessel is swollen and the width is increased, causing some leakage of the blood that leads to back pain. Guys, the only condition or the only time when the abdominal aortic aneurysm causes back pain when it's causing the leakage. Management, admit 100%, senior 100%, investigations, blood, full blood count to exclude anemia because there is bleeding, blood group and cross matching because this patient will need blood transfusion and surgery. ultrasound in the tummy, symptomatic, oxygen, IV fluids, and lifestyle modification because it's acute. We can discuss it later. You can say to him some lifestyle modification will need to wear compa. We can discuss this later. Specialist urgent referral to vascular surgeon, specialist in blood vessels who will do surgery in order to correct this condition. Okay, either open surgery, it's open aneurysm repair, cut in the tummy and graft, or endovascular repair, which is a graft that will be inserted in the blood vessel. However, you don't need to go into details of surgery, just vascular surgeon referral. Safety netting, if you feel dizzy or if you feel about to faint, let us know. Second case, back pain due to trauma. Back pain due to trauma. In this case, the patient will say to you, doctor, I played squash yesterday. I played squash yesterday and I haven't been playing squash for a while. Trauma, sport. Okay? So, 25 years old, patient has Rayo. Okay, he came to the A&E with back pain. How can I help you? Doctor, I have back pain. Back pain. I'm really sorry about that. Tell me more. Socrates. When you ask about Socrates, he will give you that the pain is 7 out of 10. In the back, on the side of the back, sharp. Okay, doesn't go anywhere else, it's just here. And he cannot move properly. And it's increasing by movement. It's been there for 4 days. For 5 days, yes. So you can ask the patient about psychosocial. You can bring the psychosocial early. How are you managing? How are you managing at home? How is it affecting your life and daily activity? And what do you do for a living? How is it affecting your job? After that, go for differential. When you go for differential, what is the first differential? And it's a must. Coda equina. Always ask about urine problem, bowel problem, sensation. No. Left heavyweight? No. Job? No. Pain, clicking sound? No. Then when you go to trauma, he had a sport. He said to you, when I was playing squash. He was playing squash, okay? You can ask about AAA, any abdominal pain, pulsatile mass, no. So maximum 4 differentials. Okay, so P2, fit and well, no problem. P3, fit and well, no problem. Maftosa, no problem, okay? Everything is okay. Examination, what would you examine? Observation and back. Observation and back. When you examine the back, you will be giving, finding the paraspinal tenderness, okay? And straight leg rest test. So, observation back and the straight leg rest test. You will be giving paraspinal tenderness. Provisional diagnosis. You'll say to him, it is muscular injury, which means that you are overstretched. You overstretched your muscles during sport. What do you need to do here in this case? Nothing. No admission. Senior. No investigations needed. Just painkiller. And I advise the patient to have a rest. Painkiller and rest. 2 weeks follow-up. So painkiller and rest. After 2 weeks, if there is no improvement, so physiotherapy. So again, admission, no. Senior. Investigation, no. This patient will be on painkiller and will have a rest. You can give him sick note. You will say to him, it will be relieved within 2 weeks. After 2 weeks, if it's not relieved, if it's increasing, then you refer to physiotherapy. Now, safety net any patient for Coda equina. Any back pain patient, safety net him for Coda equina, which is problem passing urine, problem passing stool, okay? Third case is disc prolapse. You are an F1 doctor in A&E, Scott, 30 years old, back pain. How can I help you? Doctor, I have back pain. I'm sorry about that. Tell me more about it. Or are you comfortable talking to me, or should I give you painkiller? No, I'm comfortable, doctor. We can talk. Socrates. When you ask Socrates, the patient will give you back pain. Doctor, the pain is here. Lower back pain. And doctor, when it happened, I was lifting heavy weight. I heard the clicking sound, all this. So pain in the back, and referred going to the back of the leg. He heard the clicking sound. And his job includes lifting heavy weight. All right. Then, when you go to differentials, trauma negative, multiple myeloma negative, triple A negative, always ask Coda equina. When you ask Coda equina, symptoms, no, negative. Then, P2, fit and well. P3, no problem. Maftosa, no problem. And the pain is not chronic, only started yesterday, okay? Examination, what would you examine? I will examine observation, the back, and straight leg rest test. Straight leg rest test, okay? Straight leg rest test will be positive. Disc prolapse is the case where the straight leg rest test is positive, okay, in examination. What is that? Disc prolapse. Disc prolapse is what do you mean by straight leg rest test positive? When he's flat, ask him to lift his leg like this while it's extended. He will feel pain at which degree? 30 to 70. So 30 to 70 is pain, okay? Like this, flat, raise, 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 raise. When it's 30 to 70, there is pain. Management, senior, no admission, no admission, senior, investigation in this case, X-ray on the back, X-ray on the back to exclude any fracture, X-ray on the back to exclude any fracture. You can do some blood, X-ray on the back to exclude any fracture. And by the way, disc prolapse, you can do neurological examination. So observation, back, straight leg rest test, neurological examination, including PR and disc prolapse. Why? Because we are always suspecting coda equina. So disc prolapse and coda equina, when they come to you, you cannot differentiate. Is it prolapse? Is it equina? So disc prolapse is coda equina until proven otherwise. Okay? So always think of it. I will tell you now how to think of it. How to think of it. So when you examine neurological, back passage, PR, all straight leg rest test, and when you go to management, X-ray on the back, X-ray on the back in the investigations, all the bloods in the investigations, all the bloods in the investigations, and in this case, I will book for him MRI in the A&E. MRI. I said it's a coda equina until proven otherwise. I cannot confirm it's not coda equina. So MRI. So in this case, MRI. Anyway, symptomatic treatment, painkiller, refer to physio for the back pain, refer to physio for the back pain. And if it's not improving, and I will advise this patient to be mobilized. If it's not improving within 6 weeks, then neurosurgeon. So the criteria to transfer to neurosurgeon if it's not improving after 6 weeks, and always safety net for coda equina. So management, no admission, senior, investigations, X-ray and MRI, X-ray and MRI, X-ray and MRI. Management, painkiller, physiotherapy. Ask the patient to mobilize. And if it's not improving within 6 weeks, neurosurgeon. So the difference between the back pain trauma and the back pain disc prolapse, trauma, ask him to rest, disc prolapse, tell him to mobilize. Trauma, nothing to do, and within 2 weeks, physiotherapy if it's continue, disc prolapse, physiotherapy from the start, and X-ray and MRI, and 6 weeks not improving, neurosurgeon. Always safety net for coda equina. Scenario 5 is multiple myeloma. Multiple myeloma case is a case where the patient is coming to you. You are an FY2 doctor, 65 years old, James. Had back pain for a long time. Blood tests were done, showed anemia. And electrophoresis shows increases in the immunoglobulin G and Ben-Jones protein and decreased platelet. So one thing is not being done, which is biopsy. Bone marrow biopsy is not being done, but all the initial investigations done. Platelet low, white blood cells low, and platelet low, white blood cells low, red blood cells low, Ben-Jones protein. But can that confirm multiple myeloma? No, that will not confirm multiple myeloma. Multiple myeloma will be confirmed by bone marrow biopsy. So it's a case of blood result. High. How can I help you? No, it's a high. I can see from my note that you are coming for follow-up for blood result. Would you like me to explain the result first, or would you like me to have a chat first? Go back to day 1, blood result structure. Doctor, it's okay, you can have a chat. What brought you from the first place for this blood result? Doctor, I had back pain. Explore the back pain. Do you need differentials? No, you don't need differentials. Because you know that you are suspecting multiple myeloma from the investigation. You know it's a follow-up case. You know blood was taken and you are suspecting multiple myeloma. So go back to day 1. Structure, blood result, no differential. However, I will ask about the symptoms of multiple myeloma, which is polyuria, polydipsia with loss, infection, anemia, bleeding. I will ask about flows, the cancer symptom, the red flags, and then I will go right away to explain about the result of the blood cells decreased, white blood cells decreased, and the marker Ben-Jones protein is found, and after that I will go to management. What is the management here in this case? What is the management here in this case? The management in this case is painkiller, which is morphine. Painkiller, which is morphine. Okay, how would I explain multiple myeloma to the patient? Explain the blood result. Explain the blood result well from the information you're giving me and according to the blood test, which is red blood cells is this, white blood cells is this, platelet is this. I'm suspecting a condition. I'm suspecting or it could be some blood disorder. However, I would like to exclude what we call it the worst case scenario, which is a condition called multiple myeloma, which is a sinister condition. For that, then management. So always, you do not confirm cancer without biopsy. You do not confirm cancer without biopsy. No biopsy, no cancer. So how do I get provisional diagnosis? Best case, worst case. Then you go to management. In management, senior, referral to hematologist. Any investigation in the GP? No biopsy, nothing. You are in the GP clinic, nothing to do but referral. Urgent referral to hematologist. Painkiller. So senior, urgent referral to hematologist, painkiller. What is the painkiller? Morphine. That's it. That's all your job in this case is the urgent referral to hematologist, blood specialist. Doctor, what will the hematologist do? He will take some sample from your bone marrow, which is the spongy tissue in your back. That's it. So your job is as simple as strong painkiller, urgent referral to hematologist for bone marrow biopsy. Nothing else in the GP clinic. You will not do anything else in the GP clinic. And safety net for dizziness, if you feel not well, if you feel sick, and you can go to the hospital right away, okay? So this is the multiple myeloma. So multiple myeloma case is medicine or blood result, number one. So the structure is history only about the presenting complaint, only about the risk factor, only about the complication. The second part is explain the result and diagnosis. The third part is management. The history, relevant history. Diabetic symptom, decrease in the blood symptom, flows. And that's it. Maybe family history and smoking, because it's a risk factor. Go to the second part, explain the result in details. Explain what you are trying to exclude in details. Best case, worst case, because there is no biopsy. You cannot say cancer unless there is biopsy. Management, nothing but refer to hematologist urgently, severe painkiller, strong painkiller, right? Guys, this is the cases of back pain, all right? Thank you very much. And the rest of the cases like fever, osteomyelitis, like ankylosing have not appeared yet. You don't want to know about it. Thank you very much.